Good morning, everyone. So we'll go ahead and start in the interest of time. My name is Frances. I work with the Kunle Hassan Eye Foundation Academy, and I welcome you all to yet another edition of our vitreoretinal lecture series. Today's lecture is lecture 7 in the series, and we'll be looking at the topic updates on management of sickle cell retinopathy. This is the program flow for the event today. I'm doing the welcome and introduction. Afterwards, we'll hear the presentation from the speaker. We'll have our interactive session and then the closing remarks. Just to give a brief overview about the Kunle Hassan Eye Foundation Academy. It is a member of the Eye Foundation Eye Care System. Eye Foundation was established in 1993 with a vision to eliminate avoidable blindness. The Kunle Hassan Eye Foundation Academy, formerly known as the Deseret Community Vision Institute, is the arm that oversees the training for ophthalmology residents and fellows, middle-level ophthalmic practitioners, optometrists, ophthalmic nurses. Today, we'll be looking at the topic called, our topic from our speaker today again is on the updates on management of sickle cell retinopathy. Our speaker today is Dr. Kwesi Inya Arthur. He's a senior clinical lecturer and consultant vitreoretinal surgeon at the University of Ghana Medical School. He trained in the United Kingdom with undergraduate education at the University of Birmingham in 2004. He had his ophthalmology training in the West Midlands Deanery and did his retinal fellowship at the Birmingham and Midland Eye Hospital, followed by a second vitreoretinal fellowship at the Manchester Royal Eye Hospital, all in the United Kingdom. While he was in Birmingham, he co-authored the retina chapter of the Oxford Handbook of Ophthalmology, and he has authored 30 scientific peer-reviewed papers. He won the Alcon UK Glaucoma Prize in 2010 and the Roper Hall Medal in 2008. Together with his colleague, Dr. Imoro Braima, they expanded the surgical retina service of the Kolbu Teaching Hospital in Accra, Ghana, and they set up the first public hospital vitrectomy service in West Africa. His current active research grants total $675,000. This includes an H3 African NIH grant and a Google DeepMind grant for artificial intelligence in retinal imaging. He serves on several national ophthalmological and academic committees. Dr. Kwesi is a fellow of the Royal College of Ophthalmology in United Kingdom and of the Ghana College of Physicians and Surgeons. He is a member of the American Society of Retina Specialists, the European Society of Retina Specialists, and he is the Secretary of African Retinal Society. Before I call him to take on the floor, I would like to share a few house rules. Please, if you are not speaking, we ask that you have your microphones muted and your camera turned off. The speaker would be the one to have his camera on and unmute his mic. This lecture is being recorded so that we can upload on our YouTube channel. Hence, we are making this request. At the end of the session, if you have any questions, you can type them in the chat box or you can raise your hand up. Dr. Kwesi, I hand over to you. Thank you so much.
Thank you very much, Francis, for that kind introduction. Great. So once again, thank you, Francis, for the kind introduction. And thank you to the Kunle Hassan Eye Foundation for inviting me to talk. I also like to thank Dr. Oderinlaw, my friend, and Dr. Okonkwo. They have been tremendous help to me personally. Ophthalmology in Africa has its peculiar challenges. And when you have colleagues who have gone ahead of you and done a lot before you, it is very worth the time to spend to get to know what they have been through, the challenges they have been through, and how they overcame those challenges. I would also like to thank Dr. Kunle Hassan for going ahead and blazing a path for many of us to aspire to. One of the things that interests me a lot is the thought process in how we learn and what we do. And one of the things that I talk about a lot, and forgive me if you've seen this slide before when I've talked in the past, is a thing called the Dunning-Kruger thought process. So everything we learn, when we start, we have to go through the Dunning-Kruger thought process. And initially, we are extremely confident. We think we know everything about the new thing we have learned. Let's say we are learning to drive, okay? Then as we drive and we realize that it's actually a little bit harder, we begin to sort of lose confidence. And then we get to a point where we suddenly think, you know, this thing is too difficult. I'll never understand how to put a car in first or how to maneuver up a hill. Then over time, we start to build confidence again, and it starts to make some more sense. Then finally, we get to the point where we can really explain the intricacies and the challenges involved in whatever it is we have learned. So using the same analogy of the car, the biting point, how to manipulate your clutch, all sorts of things like that. So the long and short of the update is that it is complicated, but we will go through it. Prior to moving back home, this was the paper that sort of formed the basis of a lot of the things that we did in sickle cell retinopathy management. And I won't bore you, but I'll share a couple of things that this paper said. This paper said that there was spontaneous regression in 32% of eyes, and that permanent visual loss was uncommon in patients observed up to the age of 26. Now I want you to file this in your memory, and we'll come back to it. I understand we have some residents, so we'll just go through just to remind everybody about sickle cell retinopathy. As we know, we have two main types, the non-proliferative and the proliferative. In the proliferative, we can have some features like this large red spot here, which is called a salmon patch. It is essentially a pre-retinal hemorrhage, a hemorrhage between the hyaloid and the ILM. We can have tortuosity of vessels. We can have arterial or venous occlusions. And we can have these things called black sunburst scars, which are changes to the RPE. Once it becomes proliferative, then we get new vessels. Okay, so the staging of sickle cell has 5 stages. The first stage is where we have arterial occlusions. The second stage is where we have arteriovenous anastomosis. The third stage is where we begin to have new vessels formation. And these new vessels are called C-fans. They used to be called retinitis proliferans, but it's actually easier to just call it retinal neovascularization. We can have other things happening in proliferative sickle cell retinopathy. We can have epiretinal membranes. We can have macular holes, vitreous hemorrhages we've talked about, and unfortunately retinal detachments, which can either be caused by traction or regmatogenous, which means there is a break in the retina. Now, the problem about sickle cell is that sometimes we cannot see the effects and we need fundus angiography to help us. Most of the problems with sickle cell happen in the far periphery of the eye. As you can see, this is the fovea, this is the temporal macula, and beyond that, there is almost no vasculature in the retina. So the problems are beyond us. The C-fans leak, and the C-fans are fragile and viable, so they can bleed easily. And when they contract, they can cause a retinal detachment. So with that in mind, we remember that that paper that I mentioned earlier talked about spontaneous regression in 32% of eyes, and that permanent visual loss was uncommon in patients observed up to the age of 26. Now, sometimes when you have preconceived ideas, it's important that they are challenged because things are not always exactly as we feel they are. Within my first year of working in Kolebu, I had these 3 patients, and this totally changed my approach and my thinking with regards to sickle cell retinopathy. I had a young 28-year-old computer programmer with asymptomatic mild proliferative sickle cell retinopathy. His other eye seemed fine. I advised him to watch and wait, and unfortunately he presented to me with a vitreous hemorrhage. I had a 42-year-old virologist colleague who had asymptomatic stage 3 mild PSR. He was advised by me to watch and wait, and unfortunately he developed a retinal detachment. By this time I was beginning to learn. I then received a 36-year-old pathologist with moderate PSR. I advised her to have laser. Unfortunately, she was traveling to Europe, and so she said she would get it sorted when she was in Europe. She got to Europe, the laser was not done, and she developed a retinal detachment. So with all of this, I went back to the drawing board, and I said, what is going on? And I think it's extremely important that we understand prevalence whenever we look at statistics. So when COVID started, and China started building hospitals and asking people to wear masks, a lot of us were confused as to what was going on. And the main reason is that we did not have any COVID. So we were not coming at it with any understanding of the susceptibility to developing COVID. And if you look at this fantastic paper by PL, which looks at the presence of the C genotype, you will see that our part of the world is where it is most concentrated. And it's almost like West Africa is the epicenter of the C variant. Okay, when you look at the rest of the world, there are some spots in Brazil, there are some spots in the Caribbean, there are some spots in the eastern United States and in the United Kingdom and France, which are mostly due to immigrants. Okay, but generally, this is where the epicenter is. And the thinking is that the mutation that caused the C genotype was happened in some parts of Burkina Faso or northern Ghana. And that's why it spread across West Africa the way it did. So there are some important stats to know. Newborn screening in Ghana of 100,000 consecutive deliveries told us that we have 315 children per 100,000 with homozygous SS and 201 with C. So that's 516 per 100,000. Okay, so we have 2% of newborns in government hospitals who have sickle cell. That's 2,000 per 100,000. When you start to think about it like that, it brings home to you the enormity of the pre-existing risk factors that we have in this part of the world. Furthermore, 33% of Ghanaians have either an S or a C. So we come to the clinical aspect. The other thing to realize is that the phenotype of this disease is markedly different in different people. So here we have a nice C fan. There's no hemorrhage. Traditionally, most people in Europe will not laser this. Okay. We have a different type where here it's even worse in terms of you can see the arterial occlusion. The C fans are not so pronounced and there is starting to be some fibrosis. We also have another version where you have marked fibrosis around the C fan. Okay, so the jury is definitely out with regards to sickle cell retinopathy and laser. Now, this is non-scientific advice. However, what we do now is that we laser almost all non-fibrosed proliferative sickle cell retinopathy who present to us, particularly if the other eye has had any comorbidity of sickle cell retinopathy, be it vitreous hemorrhage or retinal detachment. We are strongly of the belief that proliferation in the African context most likely needs treatment. And the two modalities we tend to use are laser retinopexy or cryotherapy. It's extremely important for us to realize that our ocular therapeutic strategy has to be different to some of the published papers, given the prevalence of sickle cell in our environment. Anti-VEGF has a role, though it is not entirely clear. At present, most of the time we use it for vitrectomized eyes with vitreous cavity, postoperative vitreous cavity hemorrhages. Now, when it comes to the laser, there's a lot of discussion as to the best way to perform laser. We theoretically have been performing laser anterior to the C fan and going into the schitic retina. However, sometimes what we find is that you can laser posterior to the C fan. So here the C fan was here, there was a bit here, and laser came here. But the challenge with this is that you're getting closer and closer to the macula and the fovea, and the risk of causing an epiretinal membrane is high. The reason why we don't tend to do this so much is that we seem to have good results lasering anterior to the C fan, but sometimes we might come posterior to it. In the old days, there was some talk about feeder vessel coagulation, but this has been proven to be extremely difficult to do and can cause all sorts of other problems. So that earlier man I talked about, where we had he had the reverend I talked about who had proliferative sickle cell retinopathy, and I didn't do anything about. He was actually not known to be sickle cell. we found out that he had hemoglobin SC. His non-clear vitreous hemorrhage was initially flat on ultrasound scan B. And when we saw him 2 weeks after that, he had detached. So once again, for vitreous hemorrhages, we have to approach them slightly differently. Now, vitreous hemorrhages also come in all shapes and sizes. Sometimes you look in the eye and you see some altered blood inferiorly. Sometimes the residents might mistake it to be a retinal detachment, but on close inspection, you realize that it is vitreous hemorrhage. The vitreous hemorrhage might be related to an active proliferative event, or sometimes you might not see where the proliferation is, particularly the vitreous hemorrhage covers it. When we come to tractional retinal detachments, rheumatogenic retinal detachments, and combined retinal detachments, there's even more phenotypic variation. I have a classic photograph here where you can see two clear breaks. But if you look here, there is also some fibrosis, and unfortunately our camera, this was before we got our Optos, so we couldn't capture this fully. There was some traction here. So in this retinal detachments, where you can see that the retina is detached of the retina there, we have two breaks and we have an area of traction. This is very different from this type of picture, where we have a clear area of traction causing a retinal detachment with this sort of pseudo hole appearance here. The kind of retinal detachments I'm most concerned about are these ones, where you have traction and you have extremely schitic retina. And I'll come to explain this later. The retina on this side is extremely thin and friable. Any manipulation, it tears or it breaks, and it can be extremely difficult to manage these cases. Yet another type where we have a large fibrovascular mass with tractional retinal detachments, a combined epiretinal membrane, which we tend to see quite closely. The other thing to realize in these cases is that the vitreoretinal interface is extremely complex. There might be vitreoschisis, there might not be vitreoschisis. A lot of the times they are young, the hyaloid is firmly attached at the disc, at the macula, and also along the fibrovascular membrane and complex. Yet another patient showing that sort of schitic retina, okay? And you can see here there's almost no retinal tissue. It's extremely atrophic and schitic. And sometimes we can pick up this thinning of the temporal retina on OCT. When you scan the patient, you notice that the retina is thinner as you go along the temporal side. For vitreous hemorrhages that come with combined cataracts, I'm extremely cautious. The prognosis is extremely guarded. An ultrasound scan can help us to delineate what is going on. If there is a closed funnel RD, almost always the game is over. If there is an open funnel RD, once again, it's extremely difficult to get any useful vision out of these. The only time
Sorry to interrupt you, Dr. Kwesi. Sorry.
Yes.
Someone is asking volume, please. Dr.
Volume.
Adjuni, are you able to hear? Because I can hear you, Dr. Kwesi. I can hear you loud and clear. They said your pointer is not showing and your volume.
I can hear him very clearly too.
I can hear him as well. I can hear him very clearly.
I can hear very clearly.
Please, we can hear very clearly. The person should adjust their own system.
I can hear.
Thank you.
Okay, thank you. Please go on, sir.
Use the speaker, use the system speaker. It will just adjust the system. Continue. You can continue, please.
Okay, thank you. So as I was saying, where there is cataract with retinal detachments, I'm extremely cautious. If the other eye is fine, I will do my best to counsel the patient out of surgery. If the other eye is not fine and there is some history that it is not, the duration hasn't been too long, we will consider surgery. This can be some of the most difficult surgery that we do. There are multiple other issues that we should consider. Epiretinal membrane, which I've talked about already, vitreoschisis, which I've partially mentioned. But the other two things that we should be extremely cautious about is that there can be coexisting arterial occlusions. Now, the reason this is important is that in counseling the patients about their postoperative vision, if there is an arterial occlusion, obviously the vision is not going to be as good as if the retinal arterial system is patent and working well. So I would indulge everyone to just assess the patients extremely well prior to any surgery. Prior to 2007, this was the largest operative case series, and it was all done with sutureless small gauge vitrectomy, and there were 18 cases. The current largest operative case series has 71 cases from 2009 to 2015. There are numerous research questions that we need to answer for our patients, and I think that we have to answer them from our part of the world. Some of the questions that come straight to my mind are immediate surgery versus delayed surgery for vitreous hemorrhage, the outcomes of surgery, which surgical technique is preferred for RD. In my personal work, I've realized that retinectomies are a definite no-no. Although I have done them and I'm sure I'll continue to do them, I would try everything possible to prevent a retinectomy. I think the way forward is more segmentation above the fibrovascular membranes. Aggressive laser, there's a question mark around that, and then the role of silicone oil. We did a retrospective study, which was consecutive interventional. We only looked at sickle cell SC, and we had to make sure that all the patients had a minimum of 6 months follow-up. It was just all my cases and the operations at 2 hospitals. We excluded all cases with combined diabetic retinopathy, and we excluded those where it was mainly an epiretinal membrane without a retinal detachment or a vitreous hemorrhage. So we're talking about retinal detachment and vitreous hemorrhage. In the period we looked at, which was 08 to 11, sorry, my apologies, which was 2016 to 2019, we had 103 surgical cases performed in that duration, and 69 people were eligible. 26 of them met our 6-month criteria for minimum follow-up. And I explained this to a lot of people that basically in our part of the world, a lot of the times when people are well and treated, after 2 months, they don't come back for follow-up because they are okay. Generally, you're left with those who have problems or those who still have oil in the eye. The age range was relatively young, as you'd imagine, from 26 to 48. There's more males than female, and the presenting visual acuities were poor. We're looking at basically 660 and worse. We had 5 only eyes. 6 of them were stage 4 and 20 stage 5, so 20 retinal detachments. The indications for surgery were non-clearing vitreous hemorrhage, retinal detachments, of which 15 were tractional, 5 were combined, and all were macular off. There were 3 who had concurrent macular holes at the same time. All the surgery was done under local anesthesia. There was no exchange transfusion. All surgery was done with 23 gauge sutureless vitrectomy. And as I explained earlier, my surgical technique evolved over time. So I became a little less ambitious and aggressive, started to segment vitreous from the neovascular membranes rather than do a large attempted delamination, which I don't think works well. Less aggressive surgery was done over time, and I started to do PRP over the areas of ischemic and schitic retina. The outcomes were that our visual acuity ranged from 0.24 logMAR to NPL, which is about 612 to non-perception of light, and the mean visual acuity was 0.7 logMAR. 24 out of 26 patients had improvement in their vision, 10 of them with vision better than 0.3 logMAR, and 14 better than 660, which is 1.0 logMAR. Unfortunately, I had to give up on 1 patient intraoperatively. Another patient had postoperative anterior segment ischemia, which is the NPL patient, and then 4 still have silicone oil in situ, and 2 of them have had second operations. We had 4 iatrogenic breaks, 7 patients required intraoperative silicone oil, 3 required reoperations, and 2 required primary retinectomies. When we compare that to the initial study by Williamson, we find that we had more retinal detachments, we had more OLI eyes, we had a similar percentage of improvement of vision, and we were more aggressive with silicone oil use. This study was limited, obviously it was retrospective. There was follow-up for the other cases, which, as I explained, generally when people are well, they don't come back after a couple of months. There was extreme surgeon's bias, as I saw way more than 126 surgical cases, but a lot of them I counseled out of surgery due to extremely poor prognosis. Due to the fact that people have to pay for surgery, there is payment bias as well. And we have a marked time to presentation bias in our part of the world, as it takes people time to get to us, it takes people time to get to a primary ophthalmologist, and it takes people time to travel to some of our centers. So we had good improvement of vision in all vitreous hemorrhage cases, which is to be expected. The retinal detachment cases can be extremely complex, particularly because the younger cases still have their hyaloid attached. There is marked postoperative retinal scarring, and that is one of the reasons why retinectomy is not advised. There are extremely high-risk complications like anterior segment ischemia, and you have to be ready to abandon a case on the table if things don't go well. So patient selection is extremely key. I think the key thing in terms of operating on these patients is the spectrum of vitreoretinal interface disorders that can be found. I showed this photograph earlier. If you look at this area with the fibrovascular changes, you see all these vessels have become white or ghost vessels, and you see there is almost no delineation of the retina here. The retina is extremely thin. Now the problem is that the hyaloid is attached all over here. So any manipulation here, you can easily cause an iatrogenic break. In the past, I used to be extremely aggressive, but now I've changed my approach. In this case here, what you will see is that I have left the fibrovascular mass intact. When I initially do the surgery, I get in, I try to get a PVD. I gently improve the PVD, take it as far as I can. Then when I get here, I cut over the fibrovascular mass. I segment on top of it. I do not try to delaminate the mass off, and I definitely do not try to peel it off. If there is any attachment of the vitreous anterior to this, I leave it be, and I do aggressive laser posterior to it. You can tell this patient has had retinal detachment surgery because if you look at the blood vessel, you'll see it looks like it has slightly moved. There's almost like a ghosting effect. And sometimes we see this when the retina settles back in its normal position. This patient has done extremely well. The other eye was blind, and he has remained stable with this management. I'll show you another one where we have once again got the fibrovascular mass, left it intact, lasered around it to keep it sort of isolated, and then get out of the eye. We're getting much better results than in the past, where we would have tried to take all of this out and been extremely aggressive, cause a large break here, which would have had to laser. Once again, this is just off camera, sorry about that. You can see that with aggressive laser, you can prevent anything from happening. You see the change in the retina here to the schitic retina, okay? And unfortunately, postoperatively, you can still get an epiretinal membrane, but this patient is okay, so we are leaving him be. I would like to end by showing this terrible picture, which is a picture of anterior segment ischemia, and just to say that there are real and present dangers in operating in these eyes, so our counseling preoperatively should be extremely targeted so that they understand the full effects of what they are going through. Once again, when we start some of these things, we think we know everything. The more we learn and the more we understand, we begin to realize the complicated nature of what we are dealing with. This is further complicated by the fact that we are not presenting our cases, we are not writing up, we are not showing other people what we have found. I hope that to the residents here, this will be a little guidance as to how to approach things, how to challenge your preconceived ideas, and how to keep asking yourself if the approach you are using is the right approach. Thank you very much.
Thank you very much, Dr. Kwesi, for this insightful lecture. We'll take questions now, questions, comments, suggestions. You can type in the chat box or you can raise your hand. Thank you. Any questions, comments? Please ask your questions.
I saw Femi Ibrahim's hand now.
Okay.
Femi, do you have a question?
Okay, Dr. Kiari, please unmute your mic and speak.
Good morning. Sorry, I'm trying to. Is it Dr. Kwesi? Thank you very much for this brilliant presentation. I think it's fantastic. I used to do some sickle cell retinopathies, very long time ago, and it's really pleasing to see that this has really evolved into what it is now as the way you practice it. My question is, I have discussed with a colleague just a few weeks ago. Unfortunately, they're unable to join the meeting today, but I was hoping that they would join the meeting today. And we were thinking of setting up a program for should I say, screening of sickle cell disease patients for retinopathy. So they have a clinic that runs for sickle cell disease, but these patients are not being screened for retinopathy. And it is a community service. So I want to also pick your brain on this. If you're going to set up a screening service for retinopathy in sickle cell disease patients, what would be the basic, setup like? It's not like a very common disease that everywhere it is there everywhere, but what would be like the basic equipment so that you'd be able to screen, and how often do you think these patients need to be looked at? That's my question.
Thank you very much. Thank you very much, Prof. Thank you also for attending. It's a very difficult question, and we have grappled with it at Kolebu. As you know, the pickup rate is extremely low, and also the disease is in the peripheral retina. So it doesn't lend itself very well to the standard camera systems that we have, which means that it has to be somebody who's skilled at examining the peripheral retina, either with an indirect ophthalmoscope or a slit lamp and lenses. So once again, either you use an extremely expensive camera system or you use an extremely skilled fundoscopist. And because the pickup rate is so low, the use of the skilled labor doesn't make much sense. And also because the equipment is expensive for the pan-retinal cameras, it also makes it very difficult for this to be instituted. So we have like an extremely difficult situation to manage in our part of the world. One of the things we are looking at is to look at if we can use some form of artificial intelligence. But once again, we get back to the camera problem. Because most of these things happen in the equatorial or pre-equatorial area, it's extremely hard for most cameras to capture them. And you saw how I even struggled to show some of the photos. We feel that what we need to work on is basically those with hemoglobin SC and have to sort of strategize some way of screening them. But we have not found something appropriate. Sorry, we have not found an appropriate method or an appropriate screening interval that makes sense given the resources we have available to us. So I'm sorry I don't have a perfect answer for you, but it's one of the things we are definitely working on in Kolebu.
Okay, thank you.
Thank you.
Oh,
but
sorry.
even if we don't have a perfect answer, what about these mobile cameras that are available? And well, there's no AI in them yet, But I guess we could help to develop that AI to recognize those far periphery retinal lesions that are seen in sickle cell disease. So one of the things I also wanted to know is like, yes, CFANs are probably the highest risk for consequences, but what about the others? You know, the sunburst, the retinoschisis, do they pose high risk for detachment or hemorrhages? What really should we be looking for apart from CFANs?
Yeah, so the non-proliferative changes really don't pose much of a risk, and the vast majority of people don't progress from non-proliferative to proliferative. So it makes using those as a screening tool extremely difficult. So one of the things we're doing in Kolebu is we are comparing a wide field camera, which is the Optos, which is on your screen now. So this is an Optos. So this is a patient with sickle cell proliferative. You can see the changes there. It's using an Optos. And then this is one of those handheld camera systems coming up. So I'll just go through. This is using a very skilled photographer in Kolebu. So he picked up that one. He kind of picked up some of this, kind of picked up some of that, kind of picked up some of this, and kind of picked up that and this. So the problem is that in order to get a good enough view to make a good discerning decision about whether the patient has to come to clinic or needs further follow-up, the handheld camera systems, unfortunately, are not adequate enough, just because of the field of view that they have. Now, if we use the other things like the sunburst and the salmon patches, they will inundate our clinics with like a huge number of people. So it's that balance between finding something effective where we can make a difference and also increasing the workload. I hope that makes sense.
Yeah, excellent. Thank you. Thank you very much.
Okay, thank you. I'll take one question from the comment before I go back to those that their hand is raised. We have a question here from Dr. Chinedu, who said, "Thank you, Dr. Kwesi, for the wonderful lecture. Please, from your experience, what is the role of anti-VEGF in the management of proliferative sickle cell retinopathy?"
Yeah, Dr. Chinedu, thank you. It's a great question. Professor Oluleye has done some work on this, and I mean, the jury is still out with regards to the role of VEGF. In Kumasi, they tried with VEGF, and one of the challenges is a thing called post-VEGF crunch. And with post-VEGF crunch, what you have is that you have marked fibrosis of the vasculature after you give VEGF. So you don't know who's going to get it. You don't know how they're going to get it. And we're not entirely sure whether VEGF itself actually does anything to the proliferative sickle retinopathy. Once again, this is one of those questions that we are looking to answer and that we feel that could do with a trial. At present, there is an international recruitment drive for a trial to look at the effect of anti-VEGF on proliferative sickle retinopathy. So hopefully we will have a clear scientific answer. In my experience, I prefer not to because I just find laser so much more controllable and useful. I know not everybody has access to laser, so it makes it easy for the use of anti-VEGF. Where I find anti-VEGF extremely useful in the context of sickle cell is post-vitrectomy cavity hemorrhages, where I have done the vitrectomy myself and I'm sure I've removed all traction and the eye is fine and they have a post-vitrectomy hemorrhage. I find that the Avastin or anti-VEGF works extremely well. Thank you.
Thank you very much. Dr. Abdusalam?
Thank you very much, Dr. Kwesi, for this really stimulating lecture. My question is about PRP laser. At what stage do you do laser for these patients, and how much laser do you do? Do you just laser the area where you have the new vessel and maybe ischemia, or do you do like a pan-retinal laser for them?
Thank you, Shuaib. Good to hear from you, my friend. What I tend to do is I laser in the the half of the eye with the problem. So let's say it's in the temporal area. I will laser anterior to the PSR, and I will laser essentially from 12 to 6 in that whole half, okay, all the way anterior. Now, I do sort of like a heavy laser immediately next to the PSR, but as I'm going out, I make it more like a PRP sort of thing. Once again, there's no evidence about whether this changes anything, but my thinking is if there is ischemic retina there, I might as well try and reduce whatever cytokines is throwing out there. So not extremely scientific, Shuaib, sorry.
No, okay, thank you. That answers my question.
Thank you. Dr. Derilo, please unmute your mic and ask your question.
Okay, it's just a comment. First of all, I appreciate. Interestingly, sickle in the southwest Nigeria, there's also a belt. So we tend to see more of this sickle cell. And sometimes when you are discussing with people from the southeast, they tend to think you are overemphasizing because they don't see that much of sickle cell as we see. So one or two comments about the screening. I think it's an excellent question, and the challenges we have also had. I like that paper you started off with. I think it was written by Sargent from the Caribbeans. And the main challenge we had with that paper was that the patients were followed up till the age of 26. Now, most of the sickle cell retinopathy that will happen will take place in the 3rd, 4th, and 5th decades. It's estimated that using Goldbach's classification, it takes a decade to go through each of the stages. So if you are looking at eyes if you are looking at the 1st decade of life, you'll be seeing them at stage 1, 2nd decade, stage 2. This is just a rough way we look at it. So he just observed them all to the age of 26, and most of them will either be in stage 2 or stage 3. He's not going to see much bleeding at that stage. And that's what we see here, people in their working age, people, professionals, students who begin to get that. And so it's tough because of where the location of the CFANs. It's not something you can just use a simple camera. You need a wide field, and even many wide field cameras that are available now, we still miss some CFANs that you could get to see with your indirect ophthalmoscope. So I agree with you. We have a lot of things to do there. I'm also interested that you do the whole hemisphere. I tend to do a quadrant, but the challenge is that we could get multiple foci of CFANs. So at the end of the day, but for me, if it's not so common, you see someone coming with a single CFAN in an angle, you're going to see multiple foci. So for each of the foci, I tend to do a quadrantic treatment. But basically, we have a lot of information to get out there. We have a lot of research to do in sickle cell retinopathy, because this is a disease that's really, I would say, it's more common, like you have shown. It's our own disease, and we should be having more information about it than any other region in the world. Those are just my comments. Thank you so much. It's been a fantastic lecture. We will call you again.
Thank you so much, Dr. Derilo. I'll go on to take further questions in the chat box. We have a question from Professor Akinshola. She said, I join order to thank Dr. Kwesi for a brilliant presentation. And the question is, how did you manage the last case of ischemia that was shown? How often do you see this kind of cases?
Thank you very much, Prof. Good to hear from you as well. Prof, it was a terrible case. It was my colleague's brother, young, I think he was about 34. he had marked proliferation, retinal detachment. So I think we had a bit too much laser. Now, the problem was that after the surgery, he went home and he had a hip crisis, sickle cell crisis in the hip. And he was complaining that his eye was hurting and he had pain, but nothing was happening. By the time he got back to us, this was what we found. We did a scleral patch graft over that area and gave him copious amounts of steroids, IV prednisolone, everything. Unfortunately, we lost the eye. We were unable to save that eye. It's the only case of anterior segment ischemia or ocular ischemia I have had following sickle cell surgery. And now I think we've done over 200 or so. So about 1 in 200 in our hands. It was extremely unfortunate and extremely difficult. And it's another reason why I've reduced how aggressive I am, particularly with regards to retinectomy, particularly with regards to laser, after seeing that case. I know it's only one case, but sometimes you need one case to change your practice.
Thank you very much, Dr. Kwesi. Well done.
Thank you, Ma.
Dr. Carey, your hand is up. Please unmute your mic and ask your question.
Oh, I was just saying, Dr. Kwesi like sent me back onto memory lane. So I wanted to just highlight that like 20 years ago, the series that Professor Mahmoud and I reported, just 6 cases, but interestingly, they were all SC as well. And so it tallies with, your epidemiological information that you gave us. And then I wanted to also, because Dr. Derinlo was talking about scatter, so in one or two of them, we did the scatter for localized CFAN areas. And incidentally, that one now developed neovascularization elsewhere. But those that had the pan-retina did not, present with neovascularization. So I'm just thinking, if we look at the pathophysiological basis of why neovascularization happens, is a global depression in, vascular, is ischemia, global ischemia. So would you now advise, Dr. Kwesi, to do a pan-retina when you do laser? Because the ischemia is global. Or would you actually just go for localized, laser to isolate? I know you the other one you isolated that lesion. So what really should we be doing? Or do we need to now look at a larger number of cases? I know it's probably not possible for us to do a randomized control trial now, but should we look at the larger number of cases and see how they fared? Have you published your series? That would be interesting to know.
Yeah, thank you very much for that. We haven't published our series yet. We are working on publishing it. We're trying to get to a number that will make it a definitive series. With regards to the laser, the jury really is out. Actually, like Dr. Derinlo, I started off doing a quadrant, a sector. And let me just, because of another question in the audience, sometimes when I'm saying laser, I'm saying indirect, I'm saying slit lamp based or clinic based laser. And when I'm saying laser, I'm saying operative laser. The one where I walled it off was operative endo laser. It wasn't a slit lamp laser. So just to clarify that for other people. With respect to clinic laser, I tend to do the hemisphere. And I started off with the quadrants, but just like Dr. Derinlo said, invariably you have more than one foci or PSR. And what happens is I just found that I was getting a larger and larger area. And also with the amount of sciatic retina, I become a bit uncomfortable because my thinking, just like you said, is that with the ischemia, what is going to happen? But my other thinking is just in case my laser causes contraction and causes a retinal detachment, I want to really sort of scar down all that area to prevent any further problem. With regards to laser, one thing we know is that the feeder vessel coagulation is extremely difficult to do and probably not worth time. We definitely know that laser works because we now have enough patients we followed up over time. We also know that it's probably better to do some form of PRP, but how much is unknown. I am definitely happy for us to pool all our laser cases, and it's something that we can look at doing between Ghana, Nigeria, Benin, Togo, and Burkina to try and have a good answer to this.
Thank you. We have another question from Dr. Shodunke. So thank you, Dr. Kwesi, for the lecture. She has several questions. I'll take it one after the other. The first one is, what is your definition of non-clearing vitreous hemorrhage or SCR? This will help with the threshold to intervene. Do you want to answer that? I should take all the questions.
Yeah, I'll answer them all. Don't worry. So for her first question, non-clearing vitreous hemorrhage normally means a vitreous hemorrhage not going away after 6 weeks. That's sort of the traditional description. Now, vitrectomy surgery has improved so dramatically that I think we really need to relook this. You know, if it was my brother's eye or my eye, and I knew it was a vitreous hemorrhage due to sickle cell and it was fundus obscuring, I would rather intervene sooner rather than later, just because of all the things I've mentioned in the past. Yes, there can be challenges with vitrectomy surgery, but by and large, modern vitrectomy surgery in the hands of a skilled practitioner is extremely safe now. So I would advocate for earlier intervention. As I said earlier, with regard to the question about the picture with the localized CFAN that had been walled off, that was endolaser. So that was somebody who had retinal detachment and then had endolaser. If you can do slit lamp laser, it is far better to do than to take them to theater to do endolaser. So it depends on the case. I don't think you necessarily need to do an FFA. I think it helps sometimes. And I think sometimes if you are not sure whether to laser or not to laser, doing the FFA might show you CFAs that you may not have been aware of. But once again, the challenge is your photographer has to be extremely skilled at getting peripheral photos because all the action is going to be in the periphery. I think that answers those 3 questions.
Okay, the next question says, I don't know if you've answered that. Sorry, I'm not a medical person. There's a point there that says you also said you do PRP for ischemic retina.
Yeah.
Does that mean we should do?
I've answered that one.
Okay, thank you. The next question is from Dr. Ogo. So thank you for your presentation. Please, is it necessary to laser auto-infected CFANs or only active CFANs?
Yeah, I in my practice, I don't, if it's auto-infected and there's good fibrosis around it, I don't laser it. I only laser active CFANs. And for those in the audience who don't understand what we are saying, in a lot of sickle cell disease, there's what we call auto-infection, where the CFAN sort of closes off and becomes extremely fibrosed. So you see more white fibrosis than red vascular. And where it becomes like that and it is clear that it has shut off, then I would not laser. This is another area where if you have access to FFA, it can help you to identify what is going on.
Okay, thank you so much. Next one was the comments. It's an excellent eye-opening lecture, so relevant to our people. Thanks so much. Next stage is advocacy for our people in diaspora, and I think that this is on a global attention. So I think persons appreciating your lecture. So are there any further questions before we bring this session to a close? Does anyone have any questions or comments? We are almost out of time. Okay, I would like to thank everyone for taking out the time to join us for this lecture. I would also like to especially thank Dr. Kwesi, our presenter, for this very insightful lecture. The Kunle Hassan Eye Foundation Retina Series occurs every first Wednesday of the month. We'll also be introducing the Community Ophthalmology Series starting second Wednesdays of the month. So the first one will be next week. And I'm happy to announce that we'll be resuming our Founders Lecture Series. We'll keep you all informed. Thank you so much. Thank you all for joining. Thank you.